This is a nice picture of the hospital out there in Abu Dhabi. Just get the slides here. There we go. How do you do a talk on lung cancer in only 20 minutes? So I decided to narrow the scope. So only randomized trials, only in the past 2 years. I gave a little wiggle room for some that were outside that scope by a few months. Treatment with curative intent trials, so we'll not be covering palliative. Potential impact on radiation therapy in a multidisciplinary discussion. And we will not review treatment for oligometastatic disease, which, as you're aware, is very important and an emerging part of lung cancer treatment, but that will be outside the scope of today's talk. And we are not going to comprehensively review lung cancer treatment, meaning I'm not going to start and go stage by stage on each treatment modality and algorithm. So the first trial that I want to discuss is actually a surgical trial. And the question that it answers is lobectomy still the standard of care for early stage non-small cell lung cancer? For many years, going back to 1995, and even before that, but the randomized trial in 1995 by Ginsberg established that lobectomy was superior to segmentectomy. So this was a randomized trial of 276 patients, and it improved, lobectomy showed improved overall survival and a recurrence-free survival. Last month, CALGB Alliance trial, published in the New England Journal of Medicine, was a trial, again, of lobectomy versus segmentectomy, but 697 patients. And this was very selected. It wasn't all patients, it wasn't all early stage patients. They had to have tumors less than 2 centimeters and in the outer third of the lung, and they had to be pathologically staged and PN0. They were randomized, obviously, between the two surgical types, and there's no difference in overall survival and no difference in disease-free survival. You can see the blue line of the sublobar resection and the red line on both of those graphs overlap. They're almost identical. And of course, because sublobar resection is lung sparing, pulmonary function was relatively less impacted by sublobar resection. And this also is similar to a Japanese trial that came out in 2022 showing essentially the same results. Okay, so why am I telling you about a surgical trial? How does this impact radiation oncology? If segmentectomy is as good as lobectomy, does this weaken the argument for SBRT? And with this data, I assume a lot of surgeons are going to be excited about this and say, okay, you could do SBRT, but I can do segmentectomy or sublobar resection with excellent results. I would rather do that. When I was training, there was an algorithm, and it was sort of an agreement in between the multidisciplinary team that if a patient was healthy enough and could be served by a lobectomy, that's the gold standard, they should go to lobectomy. If they absolutely cannot get surgery, but they needed definitive treatment, they would get SBRT. And then what do you do with the patients in between? And we had argued, and based on comparisons of the data, that local control is a little bit better with SBRT than some of the retrospective segmentectomy data. And so we had made this truce where if it was lobectomy, it would go to the surgeons. If it was anything less, it would go to radiation. And so now the surgeons could argue, well, segmentectomies for these selected patients is as good as lobectomy. And then conversely, if lung sparing is good and with good outcomes, isn't SBRT the ultimate lung sparing definitive treatment? So could we make an argument that we need to explore SBRT more aggressively with randomized trials? And then are the CALGB results applicable to community practice setting? So when I think about thoracic surgeons that I've known over the years, how many thoracic surgeons pathologically stage a small, less than 2 centimeter peripheral lesion? How many of them order EBUS on that all the time? Or how many will just go in and say, well, I'll check the lymph nodes while I'm there? And so the important thing to remember is that this was in a very controlled environment with selected academic thoracic surgeons that may not be applicable to the community practice setting. The surgeons might not have the same outcomes. And so this requires further study. There are 2 ongoing trials. The first will be estimated to finish accrual next year, and the next in 2027. These are now comparing sublobar resection versus SBRT. We had the randomized trials that were attempting to compare lobectomy versus SBRT, like STARS and ROSELLE, which did not accrue. So now the standard is shifting to comparing surgically sublobar resection versus SBRT, which is the new conversation we need to have in our tumor boards. What about post-operative radiation therapy? The French lung adjuvant radiation therapy trial was published in December of 2021. And this has been a debate going back a long time where, well, it looked like there was local control benefit, but with very crude early radiation oncology techniques, it looked like there was a survival decrement with radiation. Of course, if you're blasting the thorax with cobalt, that's not going to be good for the patient. And then with more modern techniques, people were doing database studies, which showed perhaps there is a survival benefit in N2 disease, so mediastinal nodal disease. This French study had 501 patients with performance status of 0 to 2. They were almost all 0 to 1. And these were patients that were resected and found to have N2 disease, and then they were randomized. And they were randomized to 54 gray and 27 to 30 fractions, so 1.82 gray per fraction, or no post-operative radiation therapy. Chemo was not specified, but 96% of them got chemotherapy. Most of those got post-operative chemotherapy, but some got preoperative chemotherapy. And as you can see there, many of the patients were what we call N2 unforeseen, or basically maybe it was very subtle N2 disease. Maybe they weren't properly staged initially. 90% were staged by PET. There's no note of how many were pathologically staged in the mediastinum. And so these are the patients where they didn't think they were N2 up front, but they turned out to be at the time of surgery. And then IMRT utilization was only 11%, so it was allowed, but not widely implemented. So the primary endpoints, overall survival and disease-free survival, no difference. You can see a distinction in those two graphs where the disease-free survival looks like it might be a little bit better in the port cohort, and median disease-free survival numerically was better at 30 versus 23 months, but it did not reach significance. There was a significant difference in the mediastinal relapse rate. So obviously, if you're treating the mediastinum with radiation in a patient that had N2 nodes, they're less likely to relapse, 25% versus 46%. But unfortunately, radiation does have its toxicities, and 23%, 6.3% versus 0.8% cardiopulmonary death. So what do we do with this data? I know personally, when this came out, it shifted how aggressive I would be in treating postoperatively. Is there ever a role for postoperative radiation therapy? What pathologic features now merit postoperative radiation? Positive margins? Absolutely. I think if a patient had an R1 resection where there's little residual disease, I'd want to talk to them about postoperative radiation therapy. If they have gross disease, R2 resection, my training is that's just an aggressive biopsy. In that patient, I would go for definitive chemoradiotherapy. What if there's diffuse nodal involvement? What if it's N2 disease in like 6 stations? They submit 8 lymph nodes or 10 lymph nodes and 8 of them are positive. What if there's extranodal extension? So this generates a multidisciplinary conversation on, yes, there's no survival benefit, but if you take just the worst actors, do those patients merit port? Is the protocol a guideline on how to plan and contour port? For the planning, I would say no, because it was mostly 3D planning, which is, we know from 0617 is more toxic in lung cancer. But for the contouring, I think it's an excellent guide. If you can get your hands on the protocol, there's always a question of if you have a station, say it's station 4R and 7, that were N positive, what do you contour? Do you contour the ipsilateral hilum? Yes. Do you contour above and below? And it's very specific based on the stations that were involved on what should be included in the targets. Advanced IgIMRT techniques would have been differently, would have come out differently, I don't know. And then finally, this was done pre-immunotherapy. So what are the implications now with immunotherapy? Immunotherapy might have better distant control. What if immunotherapy was done preoperatively? What does that pathology mean? So that's an open question. Next trial, neoadjuvant chemo immunotherapy trial. So this is Checkmate 816. So this was 358 patients. They were stage 1B through 3A, but 63% were stage 3A. So this is almost a stage 3 trial. However, we don't want to take the results of this and compare them to the Pacific trial because 37% of these patients were very early stage. And 43% were low PD-L1. They excluded patients with targetable EGFR and ALK mutations. And they were randomized to either chemotherapy, platinum-based chemotherapy and nivolumab versus chemotherapy alone, followed by resection. Primary endpoint was event-free survival, and event-free was defined as free of progression, recurrence, or death. And this was significantly improved in the nivolumab group. There was a trend towards median overall survival benefit, which will be significant with further follow-up, which will be important with further follow-up if it becomes significant, but median overall survival was not yet reached in the trial, so that can't be definitively reported. The pathologic complete response was 24% in the patients that got nivolumab along with the chemo versus 2.2% with chemotherapy. It was even higher, it was 44% in patients that had a high expression of PD-L1. So this compares to the intergroup 0139 trial of preoperative chemoradiotherapy, which some of us do, and I used to do it in the past at some points, for stage 3 patients that were planned for surgery. And that was only a 14% path CR rate. That's going to come into play if you're having a multidisciplinary discussion. If you are a center that was continuing to do preoperative chemoradiotherapy, I'm sure the medical oncologists are going to say, well, but we had better path CR rates. It's not a clinical outcome, but it is a pathologic histology outcome. There was no significant difference in adverse events. How does this impact radiation? There's a risk of over-application. So remember, all these patients were deemed resectable up front. So if you get into your tumor board and the surgeon says, and the medical oncologist say, well, this patient doesn't look quite resectable, but maybe if we give them chemo and immunotherapy, there's no evidence for that. It also did not include stage 3B. So I did encounter one discussion where there was a patient that looked initially that they might be stage 3B, and someone had mentioned this trial, and that was totally excluded. That category was totally excluded from this trial. What about neoadjuvant chemo RT? I already touched on that. It is, it's harder to justify with this randomized trial, to be honest. Could we attain the same path CR rate if that's what's important in the discussion? Sure, there's the missile trial of SBRT prior to resection that has 60% path CR rate, but you obviously cannot do that in a stage 3 patient with lymph nodes in the mediastinum. When to off report. So this goes back, how does this impact the LungArt trial? So LungArt trial was majority of patients were N2 positive prior to systemic therapy. So if you have a patient that has chemotherapy and immunotherapy, and then you operate on them and they have an N2 node positive, what do you make of that? Is that more aggressive disease? It's been through this aggressive regimen and still survived? And if local control more important now? In other words, in LungArt, you did decrease the mediastinal recurrence. And if that's your main concern about recurrence, if you can decrease the distant metastasis rate with improved systemic therapy, does that bring radiation back into the picture? Finally, what do you do with the patients that didn't get surgery? So 15.6% of the patients did not make it to surgery. This number might be higher off trial in the community or lower, but what do you do with them? So they got chemoimmunotherapy. Do they now go to just radiation? Do they go to definitive chemo RT plus durvalumab? What's the role of durvalumab if you got nivolumab up front? So all those are unanswered. Will it impact treatment guidelines? Here's a segment of NCCN guidelines used widely in North America for stage 3. You see, this was updated just weeks after the publication, and I don't know if it fully included the checkmate data. So if a patient is stage 3, they're T1, T2, T3, and they have N2 nodes pathologically positive, this guideline is still recommending concurrent chemoradiotherapy as category 1, meaning randomized evidence, but they're also saying, well, you can do induction systemic therapy plus or minus radiation. So it's very, it's still undefined a little bit, and I don't know how this will evolve as people start to digest the data. I will note those guidelines do not include induction chemoimmunotherapy for stage 3B patients. Finally, the next trial is the Pacific trial 5-year update. So we all know the Pacific trial published in 2017, essentially unresectable stage 3 patients, any PD-L1 level, and they received chemo RT. Most of them were 60 to 66 gray. It did allow 54 gray. I've only done that when there's just no way to meet dose constraints and I really want an attempt at definitive treatment. And they got at least 2 cycles of chemotherapy, and then they got 12 months of nivolumab, starting within a 42-day window, or placebo. It was a 2-to-1 randomization, so 2/3 of the patients were in the immunotherapy arm. This now has 5-year updates. The overall survival benefit continued, and most failures were in the first 2 years. So this can be interpreted as it wasn't just delaying treatment. It wasn't, well, we gave them a year of durvalumab and that pushed the cancer recurrence off. The decrease in recurrences appears to be permanent, so we can start talking about this as curative. Is the additional benefit from durvalumab local or distant? Now, this is a little on the table. It's a little difficult to read because remember, it's a 2-to-1 randomization. So if you're looking at the numbers and they're equal, you have to look at the percentages next to them because, of course, there are twice as many patients at risk in the durvalumab arm. So the answer is it was both. It was 24% versus 33% on, I'm sorry, 13% versus 18% in the lung. But it significantly decreased liver, bone marrow, and adrenal metastasis, so in brain metastasis as well. So there is a systemic effect of reducing distant metastasis from the durvalumab, which was a significant contributor to its survival benefit. So considerations from this, the addition of durvalumab is curative, it's not just delaying relapse. Decreased metastasis rate is contributing to survival benefit. The thorax is still the most common site of failure, so we still need to look at, are there ways to improve local regional control? And does this translate to operable stage 3 patients? I just showed you the guidelines for stage 3 unresectable, which had chemoimmunotherapy. But what do you do if it's stage 3A? Is this going to be chemoimmunotherapy followed by surgery, or is it going to be durvalumab? It looks like I'm a little short on time, so we'll rush through the last one. You have to include something about small cell lung cancer. I was at a discussion about 2 years ago where a medical oncologist from the University of Michigan said there's nothing more we can do for radiation for small cell lung cancer. It has to be systemic therapy, probably immunotherapy. There is a lot of movement in that direction, incorporating atezolizumab, et cetera. There's this one trial, this randomized Norwegian trial that came out where they basically, for limited stage, increased the dose. So instead of stopping at 3 weeks of BID radiation, they went to 4 weeks. And so it's 60 gray delivered in 1.5 gray BID instead of 45 gray with the same chemotherapy. The difference was dramatic. Overall, 2-year overall survival was 74% instead of 48%. Median overall survival, 37 months versus 22 months. And progression-free survival, 18 versus essentially 11 months. The concern would be if you're increasing the dose, aren't you going to cause more esophagitis and pneumonitis? I think that's a valid concern. I think it's something to be very cautious about, but at least in the data, it did not show up. There was a slight increase in grade 3 to 4 esophagitis, but it wasn't significant. And so what are the considerations in this trial? The strength is it's a well-designed randomized trial, and the survival benefit is significant and dramatic. We get excited about 5% overall survival benefit in small cell lung cancer. That's why that was the argument for doing PCI. This is much higher. This almost doubled the 2-year overall survival. Weaknesses, even though it's a decent sized randomized trial, it's only phase 2. And then additionally, as small cell lung cancer moves to the era of immunotherapy, it's hard to decide how to implement this, if at all, in your clinic. And thank you very much.